about the first, second generation LMAs. Anything specific that you want to know? So, I think the first generation, Blockbuster. Blockbuster, we are searching for Blockbuster for some time. It was here, sir. I think they've taken it. So, it is. Although it's a different company. It's a different company, and probably he didn't want to do it in this site, so he has taken it off. We could have at least showed you this thing. So, probable some people claim it as third generation LMA. So first generation we know airway tube, second generation with a gastric access port. So anything more to this one is termed the third generation LMA. So mostly differences in cuff design. Okay, the one third supposedly claim third generation that I've used is Baska mask. I've used it some 4-5 times. அதில் பார்த்தீங்கன்னா yes, it has a sump like thing which where the secretions can come and accumulate and you can suction it out. That's the only difference. I mean, that's one of the difference. It has a cuff which does not have an inflation system. They say that it seals with positive pressure. So every time you positive pressure ventilate, they say that the seal forms. So the maximum oropharyngeal leak pressure, they say is even up to 60 centimeters of water. I don't know. I've seen people like Dr. Ram did a lot of thing on Baska mask. So I've been with him in he does cases. So he says we can do cases comfortably till a seal pressure of 40 centimeters of water. Okay, more than that I haven't tried, and very rarely we reach airway pressures more than 40 centimeters of water in during ventilation of a normal patient. In that case, if you anticipate, say, a morbidly obese patient or something, you don't go for an LMA at all. Why do you want to put an LMA and worry about seal pressure when you know that the pressure is going to be more low? Okay, so all the others are familiar with LMA. It's actually very difficult to do this one. So okay, yeah. So this is another second generation LMA. It's called a gastro LMA. Okay, mainly designed for UGI scopies. So if you see here, this is the airway tube. This tube will be the drain tube. What looks like a drain tube is the port through which you introduce the GA scope, the endoscope that the gastroenterologist uses. So you put an LMA like we normally do. Okay, you connect the circuit here, and the endoscopist will put in their scope through this one. So the thing is, you can continue to maintain airway and maybe maintain inhalation anesthetics. Most commonly, we give IV anesthetics to keep the patient moderate to deep sedation. Okay, you can continue to give gases, reducing the risk of airway collapse, airway obstruction. Okay, so this one will come through this one. Tough to know. So it has a inflation system there. The same thing like you normally do. So just for his benefit, I'll tell. So the classic, probably the prototype Mari. So the insertion technique, a lot of things. Well, I'll just tell you the classic technique. First on the sniffing portion. I prefer to do it in sniffing portion. Generally, there is a guy called Dr. Brimacombe who did a lot of studies on LMA. So he has written a book on laryngeal mask airway, in which I still remember, I read it some 10 years before. He mentions that LMA is a forgiving device. Okay, because however you insert, it goes in most of the time. Okay, you need not follow ideal techniques. If you just push it and show it inside the mouth, most of the time it does fit properly. Okay, and it doesn't require the technical expertise of an endotracheal intubation or a direct laryngoscopy. So otherwise, on the day, keep the patient in sniffing position. Okay, lubricate it nicely. Okay. You have to extend the head. So how textbooks describe head extension is use your non-dominant hand. If you're a right-handed person, use your left hand to extend the head like this. So this when you extend the head, the mouth automatically opens, and you hold the extended head with this hand like this. Okay, keep the head in extension. I have tried it, but not persistently. Maybe some 4-5 times when I started using LMAs, I don't find it very comfortable. So I have moved to the normal technique of using it and supporting it on your tummy. Okay, so whatever. So you hold the LMA cuff like a pin. This is the point where the LMA mask is attached to the airway tube. So hold it like a pin with your index finger at this point. Okay. Extend the head, lean over. Okay, you have to see, you can't like stand here and put the LMA like this. Okay, so you have to lean over. Okay, lubricate it nicely with not with water, with some water soluble jelly. So place the tip behind the teeth. Okay, the main thing here is you force the LMA along the palate, not along the floor of the mouth. Okay, if you force it like this, if you force it along the floor of the mouth, what it is going to happen, it's going to take the tongue posteriorly. So at one point, the tongue will get between the LMA and you won't be able to insert it further. Okay, so extend the head, keep the tip of the LMA behind the central incisors on the hard palate, slide it along the hard palate. Okay, as long as you to whatever depth your finger can go inside the patient's mouth. Okay, after this you can use your left hand, hold the tube and push it inside. Okay, it's slightly difficult to do on this mannequin. So once the maximum length to which you can insert the finger, you have reached that point. You hold the LMA with your other hand and just push it inside till you feel a resistance. Once you feel a resistance for any anesthetic procedures, be it a central line, be it an epidural, catheter removal, or whatever, encounter resistance, you stop. You stop, assess, and then decide what you have to do. Then you inflate the LMA. So most of the LMAs will have a recommended volume that you should put. Okay, so for a size 3 LMA, most of the LMAs it takes up to 20 ml. 3 is 20, 4 is 30, 5 is 40. Some one number kammiya irukum. Remember that 20 ml is the maximum volume that you can put. Okay, don't exceed 20 ml, but many times you can achieve a seal with less than 20 ml. So the recommended initial volume of inflation is 2/3 the recommended volume. So on the 20 ml or 2/3 or 14 ml. So what you can do is you just put 14 ml, see how the seal is. If the seal is okay, just continue with the 14 ml. If you feel there is a leak, then you insufflate more air till you reach 20 ml. So பண்ணும்போது நார்மல் பேஷண்ட்ஸில் வந்து ஒரு ஸ்லைட்டாக அப்படி வெளியில் வரும் அந்த LMA when you inflate the cuff. All these are indirect indicators that you place the LMA right. ஓகேங்களா, then you connect your ambu and start ventilating. ஓகேங்களா, so yeah, this is the thing. So in the technique of வந்துட்டு like placing the LMA, pushing out வந்துட்டு, as you can imagine, the requirement is that the tube must be stiff. So if the tube is not stiff, if you push it from outside, it will bend. Say for example, take this one. Okay, this is called a ProSeal LMA. Okay, it's a second generation device because it has separate channels for ventilation and it has separate channel for gastric tube. Okay, idhula vandu enna pathina, if you push it inside and if you try to push through this, it will bend. Okay, so one requirement for you to actually manipulate from outside is that if the tube is stiff, it's okay. Okay, you can insert the LMA without using any special devices, but the company recommends using this one called an introducer. Okay, this is called an introducer for flexible LMA, for ProSeal LMA, which will facilitate easy insertion. Okay, so these two are LMAs with straight tubes. Okay, so the next modifications are LMAs which are curved like this. So this is a first generation device with a preformed curvature. So the concept is airway is not straight. Okay, airway is curved. So if you have an LMA which is also curved, it will make insertion easier. So eventually, like I told in the class, the final bottom line is choose a device of your choice. Okay, so personally, so this is another device called iGel. So which, if you see, it does not have any inflation system at all. It has a very soft cuff. Okay, it's a second generation. The cuff is there, but inga mela pathina it has a airway tube and a gastric tube. We have used in quite a number of patients, but personally, if given a choice between an inflatable LMA and this one, say LMA Supreme and this, I'll choose an LMA Supreme because I have the psychological thing of putting in air ensures good seal. They say that this fits in perfectly. That like what I'm trying to tell is it's your choice basically. So choose one device which you are comfortable. So for me, it's till now it's ProSeal LMA. Something with an inflatable, preferably something curved or preformed like this. Introducer. So how you load it is a small element, 2.5. There is an adult size, but I put it because it's easier to insert this one. Here you can see a sleeve which is liftable, right? So இது வந்து இப்படி உள்ள வந்து விட்டுக்கணும். விட்டுட்டு இங்கே வந்து பார்த்தீங்கன்னா 2 ஸ்லாட் இருக்குது. ஒன்று பெருசாக இருக்கும், ஒன்று சின்னதாக இருக்குல்ல. இந்த பெருசாக இருக்கிறது will be your is a slot for the airway tube. So you just bend it slightly and keep it like this, and the small one is for the gastric tube. So this will be the position. Okay, so now, like I told, it is now more curved. It's not straight. Okay, you have overcome the problem of flexibility. முன்னாடி ஃப்ளெக்சிபிளாக இருக்கும் போது what I told us, if you push it from outside, it will bend. But now you have curved it and you have loaded it to a rigid tube, to a rigid surface. So now, even if you try to do it, it won't bend. Then the usual thing, you just keep it on a sterile surface, deflate the cuff fully, make sure it is flat, apply jelly on the dorsal surface on the distal end of the air tube. So இது வந்து introducer வந்து 2 parts. The introducer blade, the introducer handle. Okay, you hold the handle. So you hold the handle, the same thing, extension, lubrication extension, keep it on the pallet, slide it along the pallet. The thing is, first you go posteriorly and then downwards, change the direction and push downwards. Okay, so posterior downward, so it goes in like this. Pannit appuram வந்து now you have to take out the introducer. Okay, so what you do is just do the opposite. So take the airway tube out of the slot, take the gastric tube out of the slot. Okay, hold the LMA because அது பிடிக்காம எடுத்தீங்கன்னா வந்து LMA வெளியில வந்துரும். So hold the LMA in place against the pallet. Just hold the handle, depress it slightly and take it down. ஓகேங்களா? இல்ல, the company recommends using the doing with this one. ஆமாமா, it comes with this. ProSeal comes with an introducer. ஓகேங்களா? So ProSeal. I don't think we can use other devices through all these slots and everything are இது adult blades, I mean adult introducer இருக்கு, which you can use for a higher. So all these things have been fixed. So அதனால வந்து the company recommends, but we used to introduce with it. So another thing is you can use a laryngoscope to introduce LMAs. Okay, you can preload it with the gastric tube. You can preload a suction catheter, do a scopy, put the suction catheter inside the esophagus, and then sort of railroad the LMA over the so there are a lot of techniques. I find the finger sweep very useful. The finger sweep. Okay, so உள்ள போட்டுட்டு எனக்கு பார்த்தா நிறைய அப்செக்ட் ஆகும்போது I put my other finger between the cuff and the palate, push it slightly anteriorly, which will create more room, and then push it inside. So whatever. அதாவது one LMA and a couple of techniques for you to adapt to. The anterior insertionலாம் வந்துட்டு I mean I've just tried it once, but insertion from the front. You can put an LMA from there. ஓகே, த திங் இஸ் ஐம் நாட் ஷுர் இதில் ப்ரோசீல் பண்ணதில்லை, பட் அதெல்லாம் எப்படின்னு பார்த்தீங்கன்னா வந்துட்டு மோஸ்ட்லி இந்த எமர்ஜென்சி ஃபீல் அவுட் ஆஃப் ஹாஸ்பிட்டல் செட்டிங்ஸ், ஒரு கார் ஆக்சிடென்ட்டில் வந்துட்டு பேஷண்ட் இஸ் இன் டிஸ்ட்ரெஸ், யூ கேனாட் கோ பிஹைண்ட் த பேஷண்ட் அண்ட் டூ திஸ். ஸோ வந்து ஆன்டீரியர் இன்செர்ஷன் அதெல்லாம் யூ கேன் ப்ராபப்ளி டிபெண்ட்ஸ் அப்பான் வாட் செட்டப் யூ ஆர் இன். ஓகேங்களா? Say when they do we used to do off-the surgeries under LMAs, pediatric off-the surgeries. So அதெல்லாம் வந்து பார்த்தீங்கன்னா வந்துட்டு we put it there, hand it over to them, but if in between ஏதாவது ஆயிடுச்சுன்னா வந்துட்டு you will probably have to insert it from there. You can obviously ask him to move away, but you can try to do it from there. So there are various techniques. I find this finger sweep, doing laryngoscope. My things are if I feel there is any obstruction, I do the finger sweep. If I feel the tongue is large, I'll do a scopy, displace it slightly, and then put in the element, something like that. So you can try. So, I mean, it's let me say that it's actually more easy to do it on real patient than doing it on this thing. I mean, I find it. The thing that you have to take care of is don't force it along the floor of the mouth. So along the hard palate, the insertion will be easier. This particular LMA is going in easily because it's small. 2.5. So just turn it. Yeah. இல்ல இப்படி வச்சுக்கங்க, எல்லாமே இப்படி வச்சுட்டு. So you want it to be curved like this. Yeah. So no, introduce இங்க முன்னாடி பண்ணிட்டு அப்படியே வச்சுட்டு you just slightly have to take it lateral, and அது flexible தான், அதனால உடையாது. அது இல்ல ILMA வந்துட்டு it is a stainless steel இது. It has an handle, but you can't remove it and all. It is fixed அவ்வளவுதான். It's pre-shaped stainless steel, but it has a handle also. இதே மாதிரி தான். So you hold it with the handle, and then you introduce it and leave it in place. The handle வச்சு தான் அந்த maneuvers up down chandies எல்லாமே வந்துட்டு அந்த handle வச்சு தான் வந்துட்டு பண்ணுவோம் actually. Video laryngoscope has drastically reduced requirement of other hair devices. ஆமாம், அது வந்து ஃப்ரீ, யூ கேன் ரிமூவ் இட். இட்ஸ் பேசிக்கலி ஸ்டெயின்லெஸ் ஸ்டீல் விச் ஹேஸ் அ கவரிங் அண்ட் அ கஃப் வித் அ ஹேண்டில். அந்த ஹேண்டில் வழியாக தான் நீங்கள் வந்துட்டு அந்த அப் டவுன் அண்ட் சாண்டீஸ் அதெல்லாம் பண்ணுவீங்கல்ல. ஸோ அது எல்லாமே வந்துட்டு அந்த ஹேண்டில் வச்சே வந்துட்டு பண்ணிக்கலாம். At the level of the teeth, it should be between these two. ஓகேங்களா? இதுக்கு மேலே இருந்துச்சுன்னா டூ டீப், இதுக்கு வெளியில் இருந்தால் டூ சூப்பர்ஃபிஷியல். So you can adjust the depth. இப்போ in the depth to which we insert the LMA, usually வந்துட்டு at the point you encounter resistance, you stop pushing it further, right? So that's again is very subjective thing. இப்போ ஐஜெல் நல்லாவே ஐஜெல் ஃபோர்ஸ் பண்ணீங்கன்னா உள்ள போய்கிட்டே இருக்கும் ஆக்சுவலாக. ஓகேங்களா? ஸோ this gives you a mark as to where to stop. So at the level of the teeth it should be somewhere between. இது adjustable, இது just fixation device அவ்வளோதான். இந்த ஸ்ட்ராப் இருக்குல்ல அதை எடுத்துடலாம். But otherwise the teeth should be somewhere between here and here. So to just make you understand whether it's too deep or too superficial, it'd be better if you have something to maintain the airway for such duration of time. பண்றது a lot of other factors, the experience of the endoscopist, the pathology that they have. I ask all these things before deciding upon the plan. இப்போ வந்துட்டு when they do ERCP stenting for a malignancy, it's usually very difficult. The patient may be all right, but they'll take a lot of time. It will be technically difficult for them. So in those cases, I go for full-fledged general anesthetic.